And if you have a system that doesn't provide hope, if you have a system that doesn't fund recovery, that doesn't build beds, that turns harm reduction into some sort of marketing term rather than genuinely trying to help people, to convince people that when, instead of treatment, we'll put resources and funds into safe supply, sort of continuing to palliate this continued addiction of the highest powered pharmaceutical grade opioids or whatever the substance is. I think that kills hope for those who see a possible life. All of my office is in recovery. Our chief of staff in the province of Alberta is in recovery. These are people of immense capacity. I believe deeply that this coin that I have is the start of hope for somebody every single day when they get to touch on that. We as a province, us as a country, need to embrace that hope. Otherwise, we're sending a message of despair to those who suffer from this disease.
Thank you, Minister Williams. I know the government of Alberta has also made many other innovative moves, specifically investing in addiction recovery supports and the recovery communities. And there are 11, as you said in your opening statement, 11, and 4 are on federal First Nations reserves. Why did the government of Alberta choose to move forward with building recovery centers on First Nation reserves when First Nation healthcare is the responsibility of the federal government? Because the government of Alberta sees this as a human and a question of dignity. These are Albertans like everyone else. We want to partner with our Indigenous community, and we're not waiting for the federal government to backfill the gap they've left. They constantly, First Nation chiefs, I came from meeting with the Treaty 6 chief, they all want to see recovery. And the federal government, the only health care the federal government is truly responsible for is on reserve First Nation. And that seems to be the only health care they're not willing to deliver when it comes to addiction treatment for First Nations. The government of Alberta is spending millions, tens of millions of dollars in not just infrastructure but programming. Well, instead, we're asking the federal government to stop pushing safe supply pouring over our border from BC and other places. I just feel like they need to, you can't suck and blow at the same time. On that point, I know you wrote a letter to the Minister of Mental Health and Addiction asking for a chemical tracer to be put on. We've now seen the government of British Columbia step on board because they've now admitted that diversion is actually a very serious problem from these so-called safe supply programs. I was wondering if you could share why the government of Alberta has asked for that, and how concerned are you about the diversion of this so-called safe supply program? The government of Alberta has made safe supply illegal in the province. That's our right. It's our responsibility under the Constitution and the division of powers. We will continue to do that so long as we are elected as a government. However, what else would you have Alberta do now other than come and plead at this committee and write letters to the minister that go, unresponded to in substance? Because we see the safe supply being pumped into 65 million pills a year. Each one of those 8 milligram pills more powerful than street heroin. Pharmaceutical-grade opioids, unwitnessed, being mass distributed. What would you have Alberta do beyond oppose it here, make it illegal? We need the federal government to take action in what is the most radical policy in the world. There's nowhere else doing this. It's a failed policy. It's devastating. I'm all for what people call harm reduction, if it's naloxone kits, if it's drug treatment centers, if it's virtual opioid dependency program, needle exchange. But it becomes harm production when you become the purveyor of the hard, powerful drugs themselves, and we oppose it.
Thank you very much, Ms. Goodridge. Madame Brière, vous avez la parole pour 5 minutes.
Ms. Brière, the floor is yours for 5 minutes. Thank you, Mr. Chair.
I know, I'm glad to see you again first. I know Minister Sachs replied to your letter and offered that officials from Health Canada discuss with yours regarding the practical issue with chemical markers. Can you confirm if that meeting happened?
I'm happy to meet with Minister Sachs anytime on this.
Not with Minister Sachs, with the officials. In her letter, she said that she suggests a meeting with officials.
I'm certainly happy to see the officials reaching.
And I think that, can you confirm if that meeting happened?
I'll ask my officials if they have had the conversation. I think there would be a sense of urgency from the minister if she understood the consequences of diverted safe supply, high-powered opioids being mass distributed into our communities. We now admit from BC that diversion's happening. The consequence of this, we spoke to a researcher out of the United States in the addiction crisis, and he says that he believes there's as much opioids on the street now as there was under the high point of the oxycodone crisis in Canada because of the safe supply being distributed by this government.
Thank you. Dr. Goulau, happy to meet you, and thank you for joining us. Earlier during the meeting, a Conservative MP said wrongly that Canada is legalizing drugs. What would you say to anyone that says decriminalization and legalization are the same thing or a word play?
Thank you, ma'am. No, in fact, I tried to explain. Those terms do not mean the same. Legalization is the regulation, turn substance legal, as we consider alcohol or tobacco, and it's different from what we did. Using drugs is no longer a crime, but under our law, it's still prohibited. It's and is punished under the administrative law. So our society continues to give a clear sign of disapproval to drug use. And I think that this makes the difference.
Thank you very much. I'll switch in French. Que pensez-vous?
What do you think, Dr. Goulau, of Alberta's approach investing in treatment instead of in a continuum of care? To take the minister's words, an approach that makes the choice between a miserable existence and mandatory treatment.
I believe in the continuum of supplying the responses that the person needs. I believe those responses must be built according with the concrete person that we have in front of you. So massive policies that offer the same thing to everybody, I do not believe that they are really effective. We must have an individual plan for each person. So, and this continuum comes from all we have a new plan, a new strategic plan here in Portugal. And it stands in 3 pillars: empower, care, and protect. And we developed our policies around those 3 ideas, according with the life cycle, with the context where the person lives and where it evolves. So I think an individual plan is key to be effective for each person.
Thank you very much. Mr. Felicella, j'ai été très touchée par...
I was very touched by your testimony. Thank you for sharing this with us. I also appreciated you saying, I do not want anyone to tell me how to live, but rather I would like them to show me how to live. In your opinion, are all drug users able to follow treatment successfully?
Well, I mean, you have to look at the individual, what they're learning in treatment, the ability to, look at life-changing avenues. And it's easy to say to people to go to treatment. It's just very hard to stay sober. And, treatment or completing treatment doesn't guarantee that you're going to be sober either. And a lot of the times people need the back end support after treatment, and they need to be shown how to get their ID back. I mean, I needed to know how to pay off past debts. I needed to go get my driver's license. I needed to know how to do a resume. You really have to teach. There's so much more that goes on than just getting off the drugs. You really have to create a new life where it's easier not to go back to the substances. And that
I'll interrupt you
is
there,
very
Mr.
easier than said
Mr.
than done.
Felicello. Madame Briere, that's your time. Thank you. Colleagues, we'll now turn to Ms. Goodridge. You have the floor for 5 minutes.
Oh, okay. Thank you again. Minister Williams, as has been kind of put forward, people like to accuse Alberta of not supporting harm reduction, and I know that that's nowhere close to the truth. So can you speak to some of the innovative plans you guys have in place, programs, specifically the narcotic transition program? Because I think that people seem to think that the only possible way of dealing with this is to give so-called safe supply and flood the streets with more narcotics rather than to do it in a medical model. So I was wondering if you could explain a little bit around what you guys are doing with that.
Yeah, thank you for the question, of course. I'll be honest, I'm disappointed in the national dialogue around language like harm reduction, safe supply. It's unfortunate they've effectively become marketing terms meant to convince Canadians of something that they intuitively know doesn't work when it comes to safe supply, for example. I kind of don't care the label anymore. If you have a policy internationally anywhere that wants to get people healthy, then I will adopt that within my program. We have the narcotic transition services, as you mentioned, MP Goodridge. We have the drug consumption sites. We have the digital overdose response app. We have virtual opioid dependency program, which is the world's first, most innovative, immediate same-day access to evidence-based opioid therapy for buprenorphine products like Suboxone, Sublocade. Products like methadone. 8,000 Albertans a day get access to that. We have mass distribution of naloxone kits. Some people call all of that harm reduction. Some people don't. That's fine. But if you call harm reduction handing out high-powered opioids at a pharmaceutical grade, unwitnessed, mass distributed into our communities that are diverted, that end up on Alberta's high school and college campuses, furthering addiction, starting new addiction, massively introducing thousands of new people into addiction, then I no longer think it's fair to let Canadians believe that's harm reduction. It's clear that's harm production. It's clear that if you're distributing the drugs, if you're the one purveying it into the community en masse, that will produce more harm. So that is my issue with it. I am not ideological coming to this beyond I want to help heal individuals to recover. And so that's my big concern, is that it's being torqued way out of context for political purposes. And I'm not going to allow the marketing terms and the branding get in the way of actually helping thousands of Albertans that struggle. So Alberta's defiantly against making, and will continue to make illegal safe supply for obvious reasons. Applying addictive drugs into a community struggling with addiction will not help the addiction crisis, but I will get them help, meet them where they are at. Meet them and bring them to a spot where they can have an opportunity at recovery.
Minister Williams, so frequently I end up having people reach out to me from all across the country explaining to me how they are contemplating mortgaging their house in order to send their child to addiction treatment, or that their child has a 2-year wait, or their sibling has a 6-month wait to get into a treatment service. The government of Alberta has removed all user fees for treatment. Why did you do that?
Previously, there was a $1,240 a month fee for someone suffering from addiction if they wanted the government access resources to addiction. Where do you think someone suffering from a fentanyl addiction is going to find $1,200 a month? Well, it's very clear that that's not a serious government policy around addiction. We increased capacity over 10,000 beds since 2019 to now. We're building 11, 4 of them on reserve with Indigenous communities, recovery treatment centers for up to 1 year of treatment, very serious treatment. We do all this to reduce all possible barriers to get people into treatment, understanding that addiction ends in one of 2 ways, either pain, misery, and tragically with enough time death, or it ends in treatment recovery and a second lease on life. There's no other third option. How could we not, as a society, invest in treatment? I'm not saying not to do everything else. Of course, we need to have a full continuum of care. I agree with every presenter's comments on that today. But the compassion in our hearts, it's so deeply un-Canadian to just let people be palliated in their addiction without a serious offer of recovery. We need to expand treatment capacity. We need to reduce barriers, eliminate costs, blow it wide open. People say, yes, that's fine. We need to build retreatment recoveries, those who oppose me. Who's doing it other than Alberta? We're putting our money where our mouth is.
Thank you. I appreciate that. Dr. Goulau, in the province of British Columbia, they've developed protocols to allow for the prescription of recreational fentanyl to youth under 18 that are struggling with addiction. Is that something that Portugal would move towards or would support?
No, ma'am. I don't believe. Hopefully, we are not dealing with the same kind of reality that you have, but I don't believe that it would be a step that Portugal would give.
Thank you very much, Ms. Goodridge. That's your time. Dr. Hanley, you have the floor for 5 minutes.
I want to thank all the witnesses for some incredible testimony today. Minister Williams, thanks for coming in person, and thank you again for hosting us on our communities tour. I'll try to be brief to you because I want to move to other witnesses, but my colleague did bring up some of the alarming increases recently in overdose death rates in Alberta, and I'm not sure you had a chance to specifically respond to that. And can you just briefly tell me your thoughts on how you're addressing that?
Yeah, thank you, and I'll try and be brief, understanding you of others that you want to address. Alberta is in an integrated illegal drug market with British Columbia. We suffer, obviously, from mass distribution of all sorts of drugs, including fentanyl, et cetera, hydromorphone, illegally diverted. And so we have a similar starting position. Happily, Alberta's continued to stay below BC on per capita and total overdose rates, an important metric for us. If we look at last year, we were 14% lower than BC on a per capita rate for overdoses, and of course, 25% lower in the first 2 months. If you look at just February in Alberta versus BC year over year, we're at 33% lower overdoses than BC is. We're cautiously optimistic that the recovery model and its culture is having a positive impact. We've seen since April last year continuous decline in overdose rates. The pandemic was brutal on every jurisdiction when it comes to this. Alberta, we believe, is starting to see some of the fruits of only 2 out of 11 of our recovery communities coming online.
Thank you. I was incredibly impressed by the Recovery Centre in Red Deer and by your help in hosting us there. At the same time, afterward, when we visited harm reduction health promotion site in the same city, it seemed a little bit of the opposite. We saw an organization very strapped for resources, feeling that their daily work with street-involved and drug-using community was actually at risk, and they were even hesitating to talk about harm reduction. And I have to say the contrast was rather striking. Putting safe supply aside and diversion aside, can you just clarify, and I think you just did, but really I want to have on the record your position on harm reduction as one of the pillars of care and as part of the continuum of care, and how you are supporting that in Alberta.
Yeah, sure. There's lots, there are many different programs. Obviously, the naloxone distribution, and that program in Red Deer distributes much of it. We have a drug consumption site for now in Red Deer. The municipality has recently asked us to review what that looks like, so we're going to take a serious look at partnering with them on that. And of course, we have narcotic transition services. So any one of those items could very easily be described as harm reduction. I have no problem with that. I need to meet people where they're at, but I need an off-ramp out of addiction as well. Else, not just as a society, but these individuals, where do they go? I can't have them just in hospital waiting rooms and chewing this tragic cycle of a turnstile in and out, not getting the care. I need to build that recovery model. I need the Alberta model to be an example to show everyone there is hope. You're not destined to die. Minister,
I'm going to stop you there if I can. And thank you very much for that. Dr. Goulau, I'll echo what Mr. John said about how important and the visit to Portugal was, that we were able to be hosted by you and last year. I just wanted, I have so many questions for you. I'll focus on how you think the system that you have established in Portugal over the last 20 years would address a toxic drug crisis such as we have here. Fentanyl, not just fentanyl, but contaminated drug supply. do you must be watching us. You must be watching to see if fentanyl arrives in Portugal. Do you have a system in place to address what could be a change in the drug supply in Portugal?
Thank you, sir, for your question. We try to track what kind of supply happens in our market, and one of the key responses is pill testing. Is testing the substances that circulate and are used by the users. And I think it's very, very important to have it in place to early identify what is actually circulating. Apart of that, we are working on the education of people, on the availability of naloxone, on preparing people for something that we know or we expect that will come to the European market with the same kind of availability that you notice in your country.
Thank you very much, Dr. Hanley. Michel Thériault, vous avez la parole pour 2 minutes et demie.
Mr. Thériault, you have 2.5 minutes. Minister, what are the numbers for overdoses in 2022 and 2023?
Décès par surdose.
So deaths caused by overdose, what are the numbers?
We have HESA, which is the Alberta mechanism we use for publicizing. It's the most integrated and transparent that I know of in the country. I have the 23...
J'ai 2 minutes et demie.
Oh,
I only have 2.5 minutes. Your numbers, please.
Merci pour la question. I have...
Thank you for the question.
...in 24 numbers in front of me. I don't want to miscite. I'm happy to get you the resources for the 2022 numbers.
2022, c'est quoi?
So for 2022...
I don't want to misquote. So the 2023 numbers is we saw a 14% lower number than we saw in British Columbia as a comparator, and the first 2 months of 2025.
Non, c'est pas ça que je veux.
No, that's not what I want. Ontario, 2022, 2,531. I would like to have one number, not a percentage. What are your numbers, please?
Provided to you. I don't have all the numbers in front of me for all the data.
J'aimerais que vous puissiez les fournir.
So I would like you to provide them, please. And what do you mean by an ideological approach? You often mention this. What is an ideological approach? Because I could say that you have an ideological approach.
Of course, all of us come to the public space with a desire that is going to be informed by our beliefs, but fundamentally, I'm not going to throw out evidence-based data and evidence-based policymaking because of a pre-existing ideological commitment. And I see that happening in other policies like Safe Supply. The data shows it's devastating, common sense shows it's not working. Nonetheless, it's continued in spite of there seems to be an allergy to the evidence to show that. So I'm about anything that brings health.
That's not what I'm talking about. You said harm reduction leads to misery. And the only hope is treatment. However, if I say that harm reduction is the beginning of treatment, what would you say to this? Do I have an ideological approach?
Treatment, but in the end, with enough time, if you only facilitate the addiction,
Est-ce que vous fournissez à votre...
Are you providing people on the ground with the necessary tools on the first line to be able to begin treatment? Or are you going to tell people in the streets, either you continue to live in misery or you can come get treatment in my treatment center?
Response, if you would, please.
I will meet Albertans wherever they are to get them the care that they need. But certain programs like Safe Supply I oppose, but that does not include a wide variety, as I mentioned, NTS, drug consumption sites. You talk about the digital overdose prevention app. I could go on, virtual opioid dependency program. Many people consider that harm reduction. I'm not ideological about that.
Logement supervisé, par exemple?
Thank you very much.
Supervised housing, for example? Thank you, Mr. Thériault.
For 2.5 minutes.
Minister Williams, the numbers are clear that 1,732 people died of toxic poison drug supply in 2022, and 2,050 people died in 2023 in Alberta. The RCMP, we had the deputy commissioner of the RCMP testify at committee, and he was unequivocally clear that police aren't seeing diversion of safer supply across BC's borders. And police also disagreed about the widespread diversion beyond a few high-profile cases. In fact, the coroner in both British Columbia and Alberta cited that only 3% of people who died in BC had any traces of hydromorphone, and they died from fentanyl, and 2% in Alberta. You talked about not enough data or research when it comes to safer supply, but the peer-reviewed research is showing that it's actually working. You haven't provided any evidence of what your claims are. These are outrageous claims. Can you show me or produce evidence to this committee that diverted safer supply from Alberta, British Columbia, is flooding Alberta?
Yes, happy to provide two answers and direct to that and address your other questions, Mr. John. Number one, we have
I'm
the
actually
RCMP.
asking if you can table that to this committee.
Yes, I will table the RCMP
Okay.
statement that they made in Prince George that they believe it's being diverted
That's
out
not
of
enough.
province.
I want.
I'm sorry, you
tabled
asked.
data.
Excuse me,
Asking you,
gentlemen,
Minister.
Mr. Johns, please. So you've asked a question.
Okay.
You know our
so I do know
notion
the
here.
rules,
Excuse me, Mr.
Mr.
Johns,
Chair?
please. You know our notion here that when you ask a question, we allow the witnesses to answer that question. I would suggest to you that the witness has about 45 seconds to answer your original question. So, Minister, if you
Mr.
would,
Chair,
please.
Mr.
Thank you,
Chair.
Mr. Johns. Minister, please.
You asked for evidence. I'll happily table that. Secondly, I have asked for a unique chemical identifying tracer in the production of safe supply from your government, which seems to be refused for technical reasons, pushing the cart down the road without doing it. That would provide everyone the evidence. I don't know why there's a concern with providing. Is there an allergy to evidence and policymaking in this government? It concerns me deeply. And when it comes to evidence around what safe supply is and isn't, the peer study you're referring to is what Canadian academics referred to as junk science because of the way it was produced.
British
Outcomes.
Medical Journal is junk science?
Because of the outcomes, they looked at 2 weeks down the road, and they also didn't disaggregate opioid agonist therapy out of that. So it's very clear. You don't need a PhD to understand giving drugs to drug addicts to address an addiction crisis will make it worse.
Thank you very much.
How's that going in
Thank you
Alberta,
very
Minister?
much, Mr. Johns.
We see improvements.
Next, Minister, thank you. Next, we will move to Mr. Doherty. You have the floor for 5 minutes.
Thank you, Mr. Chair. I'm going to move away from the hot topic of safe supply and would like to ask our colleagues or the witnesses this. We, as a country, we seem, I guess, weak and not able to stop these harmful drugs from flowing across our borders, whether it's fentanyl, carfentanil, and the precursors to these. So to the witnesses that are on there, I'm wondering if they've all got an idea or a suggestion. Mr. Felicella, you've been on the street. You've said that you've dealt in that. So I'm interested to hear your side on how we can, as a nation, stop these harmful drugs from flowing across our borders or into our country.
Yeah, that's the million-dollar question. I mean, honestly, it's just been an absolute debacle because you just can't stop drugs from getting into the country, unfortunately. I guess, the thing that you can consistently look at is they try to reduce it. But I've seen more drugs in prison than I've seen on the street in some circumstances. So the reality is that you're not going to, unfortunately, stop the flow of drugs from getting into the country or the precursors. And usually what happens is that it takes so long. You may get the low-level street dealers, but you don't get the big guns. We never get them. I mean, these people they're not even in British Columbia. They're in countries like Fiji and Vietnam and running an operation globally. I mean, this global war on drugs has really just provided an avenue for drugs to go everywhere. And these people are effective and efficient and understand what needs to be done. And they understand that there's also no shortage of people in the world that use those substances. So unfortunately,
sorry to cut you off. In your view, should Canada ban those precursor drugs?
Well, I mean, I don't know which drugs they are. They probably already are banned, but they still get in. I mean, drugs are banned in the country of Canada. Like, you're not allowed to, have fentanyl or produce it or sell it, but it still comes in the country. So,
thank you for that, Dr. Goulau. Our provincial health director of health, Dr. Bonnie Henry, testified at our committee last week that she's in favor of legalizing deadly drugs like cocaine, heroin, meth, and fentanyl. Do you support that?
I quote Mr. Felicella. It's $1 million question. I'm not sure. I believe that everybody wants to lower the impact of the use of substances in our societies. I'm not sure which is the best way to do it, to deal with them. In a regulated market, probably it's easier to track them, to follow, to have good quality products circulating. But will people tend to use more? Will deaths grow? Not sure about the consequences with this type of substances. Even with cannabis, it's not completely clear what is the impact of legalization / regulation of the market. So, not sure.
In 2023, overdose rates in Portugal were reported to have hit a 12-year high. What was the nature of that? Why is that?
In 2023, we had 74 overdoses deaths. Most of them are related to opiates, namely to heroin, and also related to crack cocaine. That's the main causes of it. I don't.
Thank you very much, Mr. Doherty. Dr. Pawlowski, you have the floor for 5 minutes.
Dr. Goulau, I'm still curious as to how the Portuguese system works. Unfortunately, we weren't able to go there to see for ourselves. So I think you either said or implied that the Portuguese system was non-coercive. Although I would suggest it is a little bit coercive because although, yes, it's not a crime, it isn't, now what was it's not, drug use is not permitted. Am I right that you kind of equated having possession of drugs as being like a traffic offense, like not wearing a seatbelt? And is that kind of the equivalent? And am I right that everybody who's caught has to go before the commission for drug addiction? And when does that happen? Does it happen right away? So.
Well, people who are intercepted by the police authorities using drugs or in possession of small amounts of drugs are addressed to those commissions. I would not say that all of them, all the people who use drugs are present anytime in their lives to those commissions. But in any case, there's an average number of 10,000 people a year that are presented to those commissions.
And so I was going to ask, how soon after you're picked up by the police do you go before the commission?
In 3 days, people must present themselves before the commission in the maximum delay of 3 days.
Now, Ms. Goodrich asked you early on if somebody was using crack on the beach, what would happen? And you said, well, the police would pick them up. They'd refer them to the commission. But what happens if they go right back to the beach again?
The police picks the person again and somehow enforces the presence before the commission.
Now, you also said, although
disobey, if you do not go, you are incurring in a disobedience felony, which is a crime. Okay, so we are not being charged by the use of substances, but by disobeying to a police intimation.
Now, I started to ask you before, and you didn't get an answer. If you go, there's no penalty. You appear before the commission. They're not going to force you if you don't want treatment. But if it's repetitive, then you can and do fine people. And how much is that fine? And if you, instead of getting fined, you go for treatment, does that mean that you don't get fined? How does that work?
Yes. I must say that for people who are addicted, that are really problematic users who have a drug use disorder, fines are never applied. There's a long list of penalties that may be applied, such as forbiddance to attend certain places or to join certain people, or the obligation to attend, for instance, the health center. For instance, if I have someone which is HIV positive and is missing the consultations, the commission may enforce that, may impose that the person attends the consultations and brings a piece of paper showing I've been there, I am complying with my treatment for HIV.
So the commission can require people to get treatment then, you said, if they're chronic users?
Yeah. Yes, to follow the obligations that...
Last question. In many cities in Canada, like the downtown east side in Vancouver, you see a lot of people with the term the nod, who are basically stoned in a public place. Do you see that in Portugal?
Yes. Yes, we see. We tend to have each time less of these situations, but of course it occurs.
Thank you very much, Dr. Pawlowski. Colleagues, we have 2 rounds of questions left, 5 minutes each. Ms. Goodridge, you have the floor for 5 minutes.
Thank you again. And I really want to appreciate all the witnesses for being here. Each time we have one of these meetings, I think we get further into this, which then necessitates the space where I believe we should continue studying and have more questions and have more witnesses come, because this is clearly something that is much larger than I think we initially grappled when we looked at this. My question is to Minister Williams. Are you aware of any jurisdictions in the world that have had success when they focus on recovery? And if so, can you provide details to that?
Well, obviously Canada is a unique country with its own jurisdictional and cultural context and milieu. So whatever we do, it's going to have to be unique to us. And even the province of Alberta, I think we have a principle of subsidiarity in the Constitution, with provinces responsible for healthcare for a reason. So the Alberta solution might look different than others, and we see 2 different policies happening in BC and Alberta, contrasting, and happy to see that we're going to have a policy outcome for both that we can use for analysis. We have looked at Australia, we have looked at Massachusetts, we have looked at Portugal, happily, as Dr. Goulau mentioned. We were there recently, spending time in depth understanding their system. So recovery is a terrific opportunity. Most recovery, when it comes to therapeutic living communities, for example, as a model, aren't instigated just by government. So you look at the world's largest, San Patrignano in Italy, started in 1978. I believe it's 1,200 person community with great outcomes. You see, I think the last study I saw from the University of Bologna had a 72% rate of success, and recidivism was relatively low. They're measuring longitudinally multiple years out. So there's lots of good information around therapeutic living communities, around recovery as a model. Recovery Capital with Dr. Best of Scotland is incredibly informative, along with a number of researchers like Dr. Humphreys, who I know you heard from here at the committee. So lots of good evidence internationally, both locally and increasingly more at a government state level.
What could the federal government be doing differently to help Alberta and Canadians more generally with addictions?
I'll speak from Alberta context, not for other provinces. As you well know, and I've made abundantly clear, safe supply is illegal in Alberta. Unfortunately, we still have the policy consequences of safe supply coming into our province from reckless, unwitnessed safe supply programs in British Columbia, for example. It is the world's most radical drug policy. No other jurisdiction does it, and is deeply, deeply devastating to a next generation of new addicts coming online. But beyond stopping that, or at the very least, if you refuse to stop it federally, employing the chemical tracers so we know the diversion, I'd say the government of Alberta has stepped forward in a very big way, partnering with Indigenous communities. Importantly, constitutionally, this is the responsibility of the federal Crown. I believe that we've stepped into a space that has been left open and abandoned by the federal government. I would like to see them come to help us with what the First Nations are asking for, which is treatment capacity, land-based, culturally sensitive, integrated and continuum of care, from shelter systems all the way through to post-recovery housing and everything in between, with the corollary investment to follow. Because right now it's falling on us. Happily, we are partnering because we believe that we need to. We'd like to see the feds also fulfill their responsibility.
Thank you. And so my next question is to Dr. Goulau. What recommendations would you give to the Government of Canada of how to improve their addiction policy to have more people find recovery from addiction?
Sir, if you could restart, you're on mute, please, sir.
Sorry. I believe that you have a lot to offer to people who wants to change their lives, their lifestyle. I need that. I believe that the coordination between the several responses is probably it's probably possible to improve the coordination and the so-called continuum of cares, from harm reduction to treatment facilities, and the way that we can captivate people to step in.
In the Canadian context, we have Northern Territories. We have 3 Northern Territories, and there isn't a single treatment center in any of those territories. We have so many of the First Nations communities from coast to coast to coast that do not have any
Very briefly,
access to treatment.
Ms. Goodridge, if you would, please.
My question to Mr. Goulau is, do you believe that Canada should be investing in creating more treatment space?
First of all, it's necessary to make a diagnosis of the needs, of what is needed in each region, and calculate a ratio for the responses, number of places available, of beds in therapeutic communities, and then to build them accordingly.
Thank you very much.
This is a diagnosis.
Point of order, Mr.
you,
Chair. Mr. Chair, given that we started 10 minutes late and we're going to have in this round will finish at 5 minutes past, can I ask the will of the committee to give the NDP and the bloc an extra 2.5 minutes each to be able to complete the full 2 hours?
If it's the will of committee, I'm here at your service. Looking around the room, that would require unanimous consent, I believe. Objections? Very well. It's a tad bit unusual. Usually we end up rounds of questionings with with the Conservative than the Liberal. But again, if it's a will of the room, I'm happy to do that. I don't see an objection, so that will do that. Dr. Hanley, you have the floor for 5 minutes.
Thank you, Mr. Falicella. I know you do a lot of work with youth. We may not have time to go too much into depth into that, but I do know that you have an interest in youth and sort of reorienting youth at risk. I wonder if you could briefly describe it and perhaps submit to the committee more details on your work with youth.
Oh yeah, most definitely. I mean, I've spoken in over 100 schools, talking to youth, sharing my story of, overcoming immense challenges throughout my life and the variety of services that helped me get to where I am today. And as a person who understands and talks to youth about my struggles that I had as a youth as well, it's very relatable to youth. And, I've had many testimonies, not only from mayors, towns, school principals, liaisons, counselors, policing. I mean, it's been very overwhelming. And just recently I did a talk at Hugh Boyd Secondary School, and youth were coming up to me after every talk. They're usually in tears. So a few of them are really struggling, and they feel so much stigma and shame because they don't have the ability or the capacity to reach out. They feel judged for how they're living their life. And the next day, the principals emailed me and saying the whole counselor's office was packed with students reaching out, saying that Guy Falicella just has a way of making reaching out sound cool. And so I really just try to inspire youth not to go down the same path that I do, but also if they do, that I want them to know that there's people like myself and others that are in community and services that do care and do want to support them. So I think it's very important for us to continue to give the youth the realities of the current crisis that we're dealing with today so that they can move forward with their lives.
Thanks, Guy. I'm going to give you a very rapid perspective. We've done, we in this committee, we've looked at Alberta a lot. We've looked at BC a lot. We've done a lot of comparing, sometimes finger pointing. I would like to see the best of Alberta and the best of BC put together. Any brief perspective on that?
Well, I mean, listen, I am concerned the way Alberta has scaled back harm reduction, but I do like their approach to recovery, getting people stabilized on out. But, unfortunately, we are seeing the results of the model through their data. And last year, BC's increase in overdose deaths from 2022 was 6.9%. Alberta's was 16.6% increase, and Saskatchewan's was actually 23% increase. So, I think we have to look at the lesson here from all of it across the country is we really have to do both harm reduction and recovery together. It's a relay race, like a baton passing back and forth as many times as possible to meet the needs of the individuals that are struggling. If you're going to meet somebody where they're at, then you know what? Meet them where you're at. I mean, I think there's one thing to say it, but access, people aren't dying from safer supply. They're dying from toxic drugs. And if that's a pathway to get people to move forward with OAT and into treatment and recovery, I don't see why anybody would be against that, because sadly, people are just dying from toxic drugs.
Thank you so much. That's very helpful. Dr. Gulao, I wonder if you can briefly talk about how you built capacity in the system, treatment capacity in preparation for decriminalizing drug use and setting up the dissuasion panels, which is some 25 years ago now, and how important that was. But I also want you to reflect on the spectrum of treatment from inpatient, outpatient, psychotherapy. If you can give a brief resume of that in about a minute. Thank you.
Okay. Well, we have a complementarity between the responses that are ensured by the state and supported by the state and the private responses that are also supported financially by the state. For instance, we have a center for outpatient clinic on each district capital. We have 18 districts. We have at least one center which has the responsibility to ensure from prevention, treatment, harm reduction, and reintegration in its territory. If they do not have the capacity to offer the responses needed in this territory, they may establish a contract with NGOs acting locally. So we built quite rapidly a network of responses. Must say that, for instance, in therapeutic communities, they are mostly private, NGO run. The state has only 3 therapeutic communities, but we have 68 run by NGOs with different models. The state responsibility is to certificate and to support the development of those communities, and then we pay for the services that they supply to our patients.
Thank you very much, Dr. Hanley. Now, the final 2 rounds of questions. Michel Thériault, vous avez la parole pour 2 minutes.
Mr. Thériault, you have 2.5 minutes. 2.5 minutes or 5 minutes? It wasn't accepted. 2.5 minutes. You can go ahead, Mr. Thériault. I thought it was accepted. Okay. Mr. Filicella, you have been a real fighter in your experience. My colleague was saying that you're a real example of how we can get out of hard times. Everyone who's come to the committee, whether they were for or against different elements of this question, accepted the idea that going back to drug use is part of one's road to recovery. And the issue here is stigmatization. Each time that someone relapses, there's a stigma automatically. Could you talk to us about this and the importance of harm reduction?
Yes, sir. Thank you. Yeah, stigma in our society is just as deadly as the drugs themselves. It's the main reason why people use alone, don't reach out for help and support. And it's the main reason why people are actually dying as well. Not just the drugs, but on top of that, the shame and, just how you feel is such a failure. You try to go into a program and you try your best. And I don't think people in our society celebrate that there are people trying. They're just not getting often the results that they need. And the reality is that toxic drug supply doesn't change when you're in treatment. It gets worse and worse and worse. And then when you do relapse, it's there to ambush you and kill you. And so we're just not going to think we're going to have this revolving door of going to send people into treatment and then back and not have a harm reduction safety net underneath that. People will die. People won't get better. And, like I said, these campaign slogans like, well, bring your loved ones home drug-free, all those sound appealing. The reality is that's not the truth. And that's why we have to have all systems of care that meet and support people's needs. If we do that and really do it in a way that we do both harm reduction and recovery equally, I promise you, we will reduce the amount of deaths in this country.
We often talk about prevention, but don't you think that we should also talk about and do more prevention of relapse?
100%. I think you have to look at our society too, is why people are using drugs, right? Go way upriver before people fall in and really give them, the tools that are in place. I mean, I think, Canada has been in a health crisis for many decades where not as much has been put into it. And, we're seeing the catastrophic results because the drug supply changed so dramatically. I think you're right. We have to do more prevention. We have to do more of everything. And that is the key to all of this. And we really have to, just inform everybody in Canada because like we've all said on this panel, I haven't been into a community where sadly I haven't seen toxic drugs impact somebody's life.
Merci beaucoup, Mr. Thériault.
Thank you, Mr. Thériault.
You have the floor for 2.5 minutes.
Well, first, Mr. Chair and committee, I want to thank you for giving us this extra round. Dr. Goulot, can you tell us, is the treatment program that your country runs for profit or not for profit?
Most of the treatment is non-for-profit. It's free of charge in the official responses in the units run by the state, and almost free of charge in private responses such as therapeutic communities. The state supports 80% of the costs, and the patient or his family must support 20% of it. If not possible, if the patient has no financial capacity, the Social Security can support the remaining 20. So nobody stays out of care by lack of financial resources.
Thank you, Mr. Felicella. We've got about a minute and a half left. Is there anything you heard today that you want to comment on, or anything you feel left unsaid? I'm sure you have lots to say.
Yeah, most definitely. I just think, people look at British Columbia and they think it's a harm reduction province. It's incorrect. It's a everything province. And we have scaled up treatment here. We have over 3,600 treatment beds right now that people can access. We also do have harm reduction service.